Hi everyone, in this lecture I will be covering congenital heart disease. Okay, so to begin I want to talk a little bit about cardiac development, at least enough so that we have a basic understanding of how some of these anomalies may occur. Okay, so let's take a look at the cartoon first. And what I want to show you is this: in this developing embryo, you can see this is the head region and this is the tail region around 18 days. And if you look closely, you'll see this is the primitive blood vessels that are forming. Up until this point, the embryo has essentially gotten its nutrients through diffusion. But as it grows, diffusion won't suffice simply because it's getting too large for diffusion to be effective. And what happens is, as these primitive blood vessels, they'll start to coalesce. All right, they'll start to come together, and they're going to start to form in an area of interest for us, which is called the cardiogenic area, which is towards the head, okay, towards the cephalic region, okay. And over here, let's take a look at the cartoon to the right of it. You'll see in about 20 days, what you have is the formation of what we call the endocardial tubes. And then the endocardial tubes around day 20 will actually fuse together. All right, so here you can see fusion of the primitive heart tube. So the endocardial tubes, once they formed, they fuse in the center, okay? And then at this point, right around day 22, 23, this primitive heart tube will actually start to beat and will start to be able to have the ability to move blood. And so this is a major step in the formation of our heart and the circulatory system. Okay, so at around day 22 here, what you're going to see is that primitive heart tube is growing, and as it grows, you'll see that it forms also these indentations. You can see these indentations, okay? And then you'll see there's some parts that are dilated and some parts that are constricted. And so these different dilatations and constrictions in the tube will actually become the future parts of the ventricle and the atria and so on. So the layout of this tube is actually that the part that's nearest the head, okay, or the rostral portion of it, which is over here, that really contains the vessels that are going to become like the aorta, the pulmonic trunk, and then as you kind of work your way down the tube, you have like the bulbus cordis. The bulbus cordis will actually be part of the formation of the right ventricle, as well as the outflow tracts of the ventricles. The primitive ventricle will be mostly becoming the left ventricle. Then you have the primitive atrium, becoming the atria, of course. And if we go a little bit further down, we have the sinus venosus, which you don't see in this cartoon, but it's written down here, sinus venosus. And that'll become part of the right atrium, the sinus of the atria, as well as the inferior vena cava, for example. So that's the orientation of it. Okay, so down here would be more caudally or towards the tail end there. Okay, and so as it grows, it forms these dilatations and has these constrictions. It starts to get larger and larger and continues to grow, and it grows within a confined space, which is really the future pericardium. Okay, and it outpaces that pericardium, and what ends up happening is it gets scrunched inside that pericardium and then makes some very sophisticated turns and twists that put it into the orientation to become the heart that we know it is. So here what you can see is these little arrows are indicating there's some sort of folding on each other as it kind of grows inside the pocket of that pericardium. And you'll see the truncus arteriosus still stays on top, but then you'll see the bulbus cordis starts to move and shift laterally over there towards to the right side. The left primitive ventricle starts to shift more towards the left and more posteriorly. And you'll see that the bottom portion here, which was the primitive atria and the sinus venosus down here, actually starts to move sort of posteriorly and upwards a little bit, because you can see part of it, which is still colored in blue over here. Okay. And now this is in its new position, so it's no longer just a linear tube, but as it's kind of folded and twisted upon itself, it now puts all those pieces into the appropriate position. So you'll notice that you have the aortic arch, okay, which is eventually going to have all of its branches. You're going to have the pulmonic trunk there. You see part of the right ventricle over here, the left ventricle over here. You can see part of the left atrium and then the right atrium over there. All right, which you can't really see there, the vena cava, which would be there. So this occurs, and again, as a sort of infolding inside that pericardial space. All right. Now, simultaneously, what's happening as this tube has come together and formed all these different regions inside the tube, which you have a process called septation. So septation is what you're looking at down here in this cartoon here. This is where we have the division of the actual chambers, because understand that really this was a hollow tube and it kind of folded on itself. And as it's done so, it's going to actually form the septa that separate the left atrium from the right atrium, and the septa that separates the left ventricle from the right ventricle, as well as the septa that separates the atria from the ventricles. Okay, so that's sort of the cross pattern that separates all four chambers. And so you'll notice one of the structures here is called the endocardial cushion, which is like this primitive gelatin-like connective tissue that starts sort of centrally, which if these are the atria up here and these are the ventricle down here, it starts in between the two and it tends to grow more horizontally. And what it'll do is it'll actually create the openings to the mitral and the tricuspid valves, which separate the atria from the ventricles. So this is forming like an atrioventricular septum. It'll also contribute a little bit to the ventricular septum, something referred to as the membranous portion of the ventricular septum, which would be just below that endocardial cushion. Okay, the rest of the ventricular septum would be more of the muscular septum, all right, the muscular wall. And then there's the septa that's going to form that separates the atria, and I'll talk about that specifically on a different slide. And then as time progresses, you can see that's occurring around 28 days. And you'll notice the timing over here, about 24 to 35 days as the tube is turning and twisting, you have the septa forming inside it at the same time. At about 8 weeks, though, you can see we actually have the formation of actual valves and the septa have formed. And if you look closely here, you can see this is my endocardial cushion, you can see just below it at this region right there, that's the membranous portion of the ventricular septum. A couple of other interesting things just to keep in mind in terms of timing. The formation of these endocardial tubes coalescing in the development of the heart starts at the 3rd week of development. All right, and by about 22 to 23 days, the primitive heart actually starts to beat. So that's when they can usually hear that, or they might be able to pick up on that on an echo, for example, after 22 to 23 days. Another important fact is that congenital heart disease is the most common form of birth defect. So now in terms of the fetal circulation, all right, so there's a specific fetal circulation because if you keep in mind, the fetus, all right, isn't breathing through its lungs, okay? Because it's an amniotic fluid, the lungs are actually kind of collapsed and surrounded by amniotic fluid. So there's no gas exchange that occurs there. In fact, importantly, the exchange of gas, nutrients, and waste occurs in the placenta. And if you look at the cartoon here, here's where the placenta is, okay? And that's where the exchange is occurring. And that's occurring via exchange with the mother, all right, the mother's blood. So take a close look over here. You see there's the umbilical vein. All right, and the umbilical vein, let me use a separate color than red. Let's try green instead. So here's the umbilical vein. You have one umbilical vein. You have the 2 umbilical arteries. And so as the umbilical vein is going towards the heart, you'll notice that it's red because it is high in oxygen content. Another way of saying that is saying it has high oxygen tension. And so it's carrying oxygenated blood or well-oxygenated blood towards the heart. Now, one thing you'll notice here is that this is a fetal bypass. You'll see this is a ductus venosus over here. And that's this right here. This is the ductus venosus. And what it does is it actually shunts about 50% of the blood flow from the umbilical vein around the liver and connects it directly to the inferior vena cava right here. So it's bypassing the liver essentially. 50% of that will go through the liver. Okay, as you can see the portal sinus right here, which connects the two. And then what that does is that brings this well-oxygenated blood to the right atrium via the inferior vena cava. Okay, now in the right atrium, it's getting well-oxygenated blood from the inferior vena cava because that came from the umbilical vein, and it's getting poorly oxygenated blood or deoxygenated blood that's coming from the superior vena cava because the superior vena cava is actually just systemic vein that's draining from the head and the upper extremities. Okay, so that's actually poorly oxygenated. So you're getting essentially a mixing of the two. but not entirely, because actually during development, they don't mix 100% here, okay? And in fact, if you look closely in the right atrium, you'll see that there is a jet, or what is it, not a jet, I should say, but like a yellow arrow pointing from the right atrium to the left atrium. So during development, there's actually communication between the right atrium and the left atrium. And in fact, the blood flows from the right atrium into the left atrium because at this point, right atrium has higher pressure and higher volumes than the left atrium does. And so it's able to move the blood over there. And this is facilitated by the fact that the septum, the atrial septum, has an opening called the foramen ovale, which I have written over here. Okay, I've already mentioned the ductus venosus, which I'll underline, but it has the foramen ovale, which is an opening which communicates the right atrium to the left atrium during fetal development, and it's appropriate. And so what happens, you'll see that sends this well-oxygenated blood almost directly from the inferior vena cava, almost directly through that septal opening, the foramen ovale, into the left atrium. So the left atrium is actually getting well-oxygenated blood almost directly, and the reason for this is that the septal wall of the atria kind of overrides the opening to the inferior vena cava. So as that blood goes moving from the inferior vena cava into the right atrium, it goes almost directly into the left atrium. Okay, so it doesn't actually spend much time mixing at all in the right atrium. It's directed almost completely into the left atrium. So well-oxygenated blood goes into the left atrium, which then of course it will follow into the left ventricle, from the left ventricle into the aorta. And you can see that it's very well oxygenated. It's still red, going into the arch and feeding the heads through the carotids, as well as through the subclavians and so on, to the upper extremities. So they're all getting well-oxygenated blood, in addition to the coronary vessels of the heart, which would also be getting that well-oxygenated blood. But there's another piece to this, and I'm going to come back a little bit here to the right atrium again. The superior vena cava is deoxygenated or not as well oxygenated, and that's coming from the head and the upper extremities. And what happens is that's directed almost directly into the right ventricle. It does not go towards the left atrium. And so it mixes a little bit with what's coming in from the inferior vena cava. And so that's why it's purple here, to show that it has sort of medium oxygen tension. And so there's a little bit of mixing that goes on, takes a little bit of that inferior vena cava blood, mixes with the superior vena cava blood, and goes almost directly into the right ventricle. The right ventricle then will eject the blood into the pulmonary trunk, which would lead to the lungs. Now, we know that, in the non-fetus, what you have is that goes to the lungs, which have low resistance and so on. But as I already mentioned, the fetal lungs are collapsed. They're surrounded by fluid, okay? And in fact, most of those vessels are constricted. And if you'll recall that the pulmonary blood vessels actually dilate in response to oxygen, so they can get more oxygen. It'll vasoconstrict when there's a lack of oxygen, and that differentiates it from systemic vasculature. So in this case, as everything is collapsed and there's not any gas exchange occurring, these vessels are also constricted, so the lungs are very high resistance, which means that blood doesn't like to go or flow in that direction because of the high resistance. And so if you look over here, this is where the pulmonary trunk is. You'll notice in this region right here, I'm circling it for you now, the pulmonary trunk is connected to, the descending portion of the thoracic aorta via what we call the ductus arteriosus. So that's the third bypass down here, the ductus arteriosus. And so what happens is, since there's high resistance in the lungs, most of the blood in fetal development will be shunted via the ductus arteriosus into the descending thoracic aorta. And that's going to mix with the blood that's coming from the left ventricle, which was of high oxygen tension. This is of a medium oxygen tension, and so on. You can see it stays kind of purple from the point at which the ductus arteriosus connects with the descending thoracic aorta. And that's going to feed, of course, the lower extremities and so on. And so that's why you see it's all purple down here into the abdominal aorta until it becomes the iliacs and so on. And then those veins will return a lot of that venous blood, through the liver and so on. But you'll also notice that there's a branch off the internal iliac arteries, which become the umbilical arteries, which send this low oxygen blood back to the placenta to attain more oxygen, right? And so this is the pattern where you have the lungs are not doing the gas exchange, but the placenta is, and there's a high volume going to the right side of the heart, and the oxygenated blood going to the right side of the heart will be shunted almost directly into the left side, with a little bit going into the right ventricle, which then gets bypassed from the lungs directly into the descending aorta. All right. Now, because of this arrangement, the right side of the heart during fetal development actually has higher pressures than the left side. So everything shunts over towards the left. It goes from right to left, from high pressure to low pressure. And this is much needed so that it can actually circulate the oxygenated blood to where it's needed, because the lungs are not functional at this point. Now, we'll discuss on another slide. We'll talk about how, well, you know, when the fetus is born, how this all changes. Okay, now I did mention a couple slides ago how we have septation. So as that basically that primitive heart tube starts to fold and twist upon itself to get into the appropriate alignment, we have septation occurring at the same time. And so it's important to kind of understand how septation, that separates the left atria from the right atria, how that occurs, and sort of the process of that. So recalling from that last slide that under normal circumstances, the right atria will shunt blood into that well-oxygenated blood into the left atria. Okay, so that's what you're seeing here in A. This is the shunt. And this right here, I'm going to use red again, so it's going to be a little bit easier. All right, that's the septum right there. Okay, and it has two components to it. Okay, it has what we call the septum primum and then the septum secundum. Septum primum, all right, as it suggests, was the first septum to form, and what it has is, you know, little pores in it to still allow blood to move from right to left. And then the septum secundum forms, and it forms right adjacent to the septum primum. And what it does is it leaves a gap in the center of it there, right here, called the foramen ovale. That's the one I mentioned on the previous slide. So it leaves essentially a nice hole there, okay, a little window for the blood to move through. At which point the septum primum is essentially one solid piece, and the superior portion has actually kind of degenerated here. And what you're left with is, since the superior portion is not connected to the wall at all, but it's connected down here inferiorly to the endocardial cushion, recalling that the endocardial cushion was that connective tissue in the center that separates the atria from the ventricles. So it's hinged down here in the endocardial cushion, and you'll see there's nothing attached to it on top. So the septum primum, which is, you know, facing the left atrium over here, acts like a trap door. And the septum secundum has a little hole in the center of it. And so what happens is you have blood, the high pressure from the right atrium pushes open the trap door of the septum primum, pushes it open, and blood can move into the left atrium. And it moves from right to left during fetal development because of that pressure difference. Now this is B is just showing you here. Here's the septum secundum and the primum. If it were to close, you see how the left atrium and the right atrium are closed off from each other because the trap door shuts. Okay, but if blood is moving, it would open up. Okay, so it acts like a trap door. In the adult circulation, this would be closed because what happens is, and we'll describe this in more detail in the next slide, is that the pressures on the left side, as you guys well know, actually are higher than on the right side after birth. Okay. So when the left atrial pressures are greater than the right atrial pressures, that actually holds the septum primum up against the septum secundum so that they're closed. And so even though the foramen ovale is still there, it's blocked off by that trap door because of the high pressures from the left side. So there is no movement under normal circumstances from the left side or the left atrium to the right atrium. And over time, usually within 6 months or so after birth, the septum primum and secundum fuse together. Okay, so let's talk about transitional circulation. So this is after, going from fetus to then just being born, where the big key here is that we go from having gas exchange occurring at the placenta, we're switching now to gas exchange at the lungs. Okay, so this is the big step, and it's going to change everything about the circulation. So if you recall, when I mentioned a few slides earlier, is that the lungs during fetal circulation, the lungs are collapsed, they're high resistance, the vessels are constricted, and so therefore there's very low blood flow actually going to the lungs in the fetus, and it gets shunted through the ductus arteriosus, which is over here. Okay. Now, what happens is this: when the lungs inflate, so when the baby takes that first cry or that breath, okay, the lungs inflate, and when they inflate, they actually mechanically will actually stretch and pull open a lot of the arteries, and at the same time, that increase in oxygenation now from pulling open the lungs will actually cause vasodilation in the lungs. So that's going to increase flow to the lungs, and it's reducing the resistance, okay, because everything is vasodilated. So it reduces the resistance drastically. And so what ends up happening is now the right ventricle, when it's ejecting the blood, it's not going, most of it's not going into the ductus arteriosus anymore. It's going towards the low resistance lungs. And so then, you know, that blood flows through the lungs. So we have a significant increase in flow going through the lungs. That means we have a significant increase in the volume that's going into the left atrium. So the left atrium via, remember, these pulmonary veins, okay? And that's going to empty a lot larger volume into the left atrium, which ultimately is going to be a larger volume for the left ventricle too. And so what happens is this: that larger volume that the left atrium is now seeing is going to translate into a larger pressure in the left atrium. That larger pressure in the left atrium is going to help to close that septum primum that I mentioned before, that trap door, so we don't get any more shunting from right to left. Okay, so that's an important step there. We block that shunt. That's going to direct all the blood that's going from the right atrium into the right ventricle. At the same time that's occurring, what happens is we, you know, when the baby is born and we've clamped off the umbilical vein, or it has constricted on its own. When that constricts, that actually reduces the amount of flow going to the right atrium. In fact, not only does the umbilical vein itself constrict, but in response to birth, the ductus venosus here will actually completely constrict as well, and will no longer have any blood flow either. So blood flow completely ceases through that ductus venosus. So we have a drop in the overall volume going to the right atrium, which also reduces the right atrial pressure relative to the left atrium, and so this is why the little trapdoor stays shut. So right atrial pressures drop, left atrial pressures go up. Now the inferior and the superior vena cava blood is going to be directed into the right atrium and then into the right ventricle. Right ventricle again is sending all that blood mostly into the low resistance lungs. Now the third and important step here is what happens with the ductus arteriosus. That's our shunt over here at point 3. What's important about this is that now you have this closing as well at the same time. And this closes in response to the high oxygen tension because of the lungs. So now when the lungs inflate, we have more oxygen there. This high oxygen tension actually causes constriction of the ductus arteriosus, okay? In fact, it's able to remain open or patent because it produces PGE1 or prostaglandin E1, which helps the smooth muscles there to relax, and it keeps it open. When there's a high oxygen content there, it causes a reduction or a drop in the production of PGE1, and so vasoconstriction occurs and it completely closes off under normal circumstances. So we lose the connection between the pulmonary trunk and the descending thoracic aorta. And so now everything is shut off and it's going to be directed in the pattern that it should be. And now the left atrial pressures are going to rise, okay, due to the higher volumes there as well. All right, and the right atrial pressures are going to drop off. Now, during fetal circulation, recall that the right side of the heart really did more of the work. It pumped out more to the systemic circulation than to the left side of the heart. And so actually the cardiac output from the right ventricle is actually larger than the left-sided cardiac output. However, as these volumes change and so on, and pressures change, the right side of the heart cardiac output starts to decline as the cardiac output of the left side starts to go up until they become equal with one another. Because as you guys know, cardiac outputs are equal both on the right and left sides of the heart. And so now this is where we have our normal picture of having the left side of the heart having higher pressures than the right side of the heart. And the key to all this was disconnecting from the placenta and having the umbilical vein constrict, and having the lungs inflate. All right. Okay, so that was just an overview of, development and fetal circulation, because anybody who's taken development knows that that was, touching on only very, very lightly on some of the topics here. But I think that's enough to hopefully help us understand some of the conditions I'm about to talk about, all right, which I broke into two categories. So we have what we call acyanotic lesions, or congenital heart defects, and we have cyanotic congenital heart defects. We need to be able to identify those, okay? So when it comes to the acyanotic lesions, I've put the list right here for you. All right, we have atrial septal defects. So this is really going to be where there's a communication between the atria. A ventricular septal defect, so communication between the ventricles. A patent ductus arteriosus. Recall that the ductus arteriosus is what connects the pulmonary trunk to the aorta. And then there's the coarctation of the aorta, where we have a stricture in the aorta itself. Okay, so let's start with the atrial septal defect. And what I like about this cartoon here, all right, is it can show you, here's the hearts, right? You can see the right ventricle, left atrium, right atrium. And you'll see this little arrow here, and that's indicating where the defect is. So we have the left atrium is still communicating with the right atrium. Recall, I'm not talking about fetal circulation anymore. I'm talking everything in it now is, after birth. So recall that should be shut. There should be no communication under normal circumstances between the atria. But the left atria, after you're born, has higher pressures than the right atria. And recall that blood flows down its pressure gradient. So it would tend to go from the left side to the right side if there is a communication. So with an atrial septal defect, there are several different kinds that it could happen. In fact, any part of the atrial septum could have a defect in it where it's communicating between the atria. And so one example of that would be something we call the foramen ovale ostium secundum. And but it's just telling you that there's an opening in the septum that's in the location of where the foramen ovale is. And the important concept here is that this is a persistent opening. This is just having an open communication between the two at all times. And since the left atrium would have higher pressure than the right atrium, the flow is from left to right. Okay, so that's an important step. Now, what I really like about this cartoon is this drawing over here. So these are really useful. So it's showing you in a box diagram the heart. So you have the left atrium, right ventricle, left ventricle. Okay, and here's our atrial septal defect, because that's the communication between the atria. And what they've done is they've darkened or highlighted the boxes here. You'll see there's a darker line around the right atrium and right ventricle to illustrate which chambers will become volume overloaded or volume stressed by this defect. And it makes sense, right? Because if I am moving some volume from the left atrium, and a percentage of that is going to go into the right side of the heart, it's going to go into the right atrium, which means there's more volume. So not only is it getting venous return, but it's also going to be getting a percentage of the blood coming from the left atrium. And that volume, again, is going to go into the right ventricle and go into the pulmonary arteries, which is what the PA stands for, and this stands for aorta. All right. So you volume overload the right side of the heart, including the pulmonary vasculature. You don't volume overload the left atria or the left ventricle, because the left atrium is shunting some of that, and the left ventricle doesn't see it necessarily, right? What you have here is a mixing of what's oxygenated, right? This has already gone through the lungs. It's oxygenated blood that's being shunted over towards the right side and mixing with deoxygenated blood. And so you can have other types of defects in the septum. But another one here, this is an important one to point out, is that what we can have is called a patent foramen ovale. This is not a persistent opening. This is still where you have the two layers of the septum where they're closed together and you have a trap door, okay? But the trap door doesn't fuse. And I mentioned earlier that the trap door essentially, or the septum primum, has to fuse with the septum secundum. And that usually occurs over several months after you're born. And if it fails to fuse, it's okay, it'll still stay closed because left-sided pressures are still higher than right-sided pressures. So it shouldn't normally be an issue. So this is why we often say it's clinically silent. But let's just say that over time somebody develops increased right-sided heart pressures from right heart failure or pulmonary hypertension or something of that nature. This can cause buildup of pressures on the right side, where the pressures on the right side could overcome the left side, and you could actually get shunting going from right to left. Okay. And another example of that is down here, or sort of a different example really, is let's say, barring right-sided pressures going up because of right-sided heart failure, you could have a paradoxical embolism wherein you have, let's say, a deep venous thrombosis, which we'll discuss in more detail in another lecture, where this, an emboli is traveling and it's going into the right side of the heart. Normally it would travel into the lungs because that's the normal pathway, but it might be able to travel from right to left if somebody, say, transiently, sneezes or coughs or something of that nature, where the pressures go up transiently in the chest, where it can actually cause that trap door to kind of just transiently or quickly open up. That could allow little emboli to actually move from one side of the heart to the other, and then that's referred to as paradoxical because they should really be going into the lungs, and instead they're going into the arterial circulation. Okay, and so an echo could actually pick up on something like that. In terms of the atrial septal defect pathophysiology, some of it I kind of already mentioned to you, where you have oxygenated blood moving from the left side over to the right side, and then in terms of the flow that goes through that atrial septal defect, that flow is proportional to the size of the defect itself and the compliance of the atria. All right, because the more compliant the atria, the more volume it can hold on to, and the less pressure there is to drive blood across that septal defect. And a smaller opening isn't going to let much flow through there because it's higher resistance. So it all depends. So you can have gradations of severity, and of course you can, in certain circumstances, volume overload the right atrium and the right ventricle, as I mentioned on the previous slide. In terms of the symptoms, it's mostly asymptomatic. Okay, this is the atria are low pressure. Okay. It can cause volume overload, and if it does happen, what you can see is dyspnea because you're volume overloading the lungs. Okay, it creates poor gas exchange, so fatigue. All right, if it's large enough, you could even be shunting it away from the left ventricle, which would also cause a little bit of a decrease in your output there. Now, an interesting kind of occurrence is that a lot of these defects and congenital defects have recurrent lower respiratory tract infections. In fact, the syncytial virus is probably the most common cause, and they are associated. But some of that association probably has to do with the impact it has on the lung, with volume overloading causing edema, maybe extravasation of fluid, and so on. Enlarging vessels can cause pressure on the lungs to cause atelectasis and collapse, and this is all, this all benefits, infection. And finally, you can also get palpitations because as you distend or stretch through volume overload and so on, you could affect the conducting system. Okay, and that can cause certain dysrhythmias. You might see a right ventricular heave from right ventricular volume overload. And as I've mentioned on the previous slide with heart sounds, you can go back to that. This causes the classic fixed split 2, which they often like to talk about on exams, or like to give questions on for exams. But the fixed split S2, okay, so regardless of inspiration or expiration, there's still a split sound from A2 and P2. There can be, mid-diastolic murmur on the left lower sternal border. Murmurs are not always heard because they are generally, the atria are low pressure, and so it's not, you may not always hear a murmur. In terms of diagnosis and treatment, so I'm just kind of giving you a list here of some of the diagnostic modalities that we use. Chest X-ray could show enlarged heart silhouette based on the right ventricular hypertrophy or atrial hypertrophy due to volume overload. Prominent pulmonary artery with increased vascular markings due to the congestion within the lungs. The ECG could show right ventricular hypertrophy and right atrial enlargement. You might see with that right atrial enlargement, it could form a right bundle branch block, might also be evident, but neither of that, none of that's diagnostic. The echo will actually give you visualization of the atrial septal defect, and you can use a Doppler and make the calculations in terms of blood flow. You can size up how big the opening is, and you can look for any kind of abnormalities of the ventricular wall and so on. So it's a very useful measure. In terms of catheterization, this is useful in the sense that you can assess pulmonary vascular resistance. You can actually get the catheter in there, measure, put that into the pulmonary circulation and measure resistance and outputs and so on. In addition, it has another useful characteristic in that it can also measure oxygen content in the blood. And so what I mean by this is that I could take the catheter, insert it through the vena cava, and I could measure the amount of oxygen in the vena cava, which we'd expect it to be low oxygen because it's venous blood. But as I move that catheter from the, let's say, superior vena cava and move it into the right atrium, I would expect under normal conditions that the amount of oxygenation would be the same. And in fact, it would be the same even into the right ventricle because I haven't reached the lungs yet. I haven't exchanged gas. So really, it should be the same from the superior vena cava into the right atrium, right ventricle, pulmonary artery and trunk until it gets to the lungs itself where gas exchange occurs, and then you'd see a step up in the oxygenation in the left atrium and left ventricle, right? But with an atrial septal defect where oxygenated blood is mixing with venous blood, what you have now is the catheter goes from the superior vena cava where it's showing me low oxygen content, and I move the tip of that catheter into the right atrium. Now I see a step up in the oxygenation, and that step up occurred before I ever got to the lungs. So that is, that's abnormal, and that suggests that I'm getting mixing of oxygenated blood. Okay, and so that would occur as I go from the vena cava into the right atrium. I'd see a step up in oxygenation, and so depending again on the severity of the opening here or the defect, you can have surgical repair. All right, where you can directly suture it closed, or you can use what you can see in this image here, a synthetic patch that can be put in place and block off the communication between the two atria. Okay, but there's about 25% of patients who actually can have atrial septal defects go unnoticed until adulthood. So it can be very chronic and insidious. A ventricular septal defect is going to be communication between the ventricles. And so looking at our cartoon over here, you can see the defect there from the left ventricle towards the right ventricle because the left ventricle is obviously going to be higher pressure. Now, if you look at the box diagram over here, you'll notice as the blood flows into the left ventricle, the defect here is moving into the right ventricle. So it's volume overloading the right ventricle. It's volume overloading the pulmonary arteries, the left atrium, because that large volume is now returning to the left atrium and returning to the left ventricle. Okay, so you can see a volume overload from right ventricle all the way to the left ventricle. Okay, and so volume overload for there, that's going to put stress and over time could increase their pressures and cause hypertrophy and so on. Now, most often the VSD or the ventricular septal defect occurs in what we call the membranous portion. And if you recall from earlier in this lecture, I mentioned that the membranous portion is the most superior portion of the ventricular septum that's created by the endocardial cushions there. And that's about 70% of them, okay? The rest of them can actually form in the muscular wall or anywhere else along the ventricular septal wall there. Now, in terms of its pathophysiology, it's similar in concept to what we talked about with the ASD, okay? Except now it's occurring with much higher pressures because it's happening in the ventricles instead of the atria. So size of the defect does matter, okay? The relative resistance of the pulmonary and systemic vasculature also affects the magnitude of the shunt. So for example, if I have a small VSD, that's high resistance. So I'm not going to get much flow there, okay? Whereas, obviously larger ones can have lower resistance, much more flow is going to occur in that circumstance. Now, in terms of the relative resistance of the pulmonary and systemic vasculature, this matters because let's say I have a high afterload, so I have let's say high blood pressure. That's going to make it harder for the left ventricle to eject blood into the aorta, right? Because the higher the afterload, the lower the stroke volume goes. And normally, if there's no septal defect, that would just put more pressure on the left ventricle and it would retain that extra volume and so on, as we learned in the heart failure lecture. However, if there's a VSD there, some of that blood then, or more of it I should say, is going to be shunted to the right side because it can't eject it into the systemic circulation. So the higher the systemic resistance, the more is going to get shunted there. And now the same thing goes with the pulmonic side of things, because in the beginning, you remember the pulmonary vasculature is a very low pressure system. But if over time that pressure starts to build up and it becomes more hypertensive due to all this volume overload and hypertrophy and so on, that can actually increase the pressure significantly enough where it starts to affect the right ventricular pressures, because the right ventricle can't eject it into the pulmonary vasculature as readily. So the right ventricular pressures go up. As right ventricular pressures go up, it's going to resist any movement of blood from the left ventricle into the right ventricle. Okay, and so that will also affect the ability to shunt. And I'm going to talk about this more in detail a little bit later, but ultimately the pressures could get high enough where the shunt could reverse. So if there's a large shunt, which is the second bullet point here, all right, so I have right ventricular, pulmonary circulation, left atrium, left ventricle are all going to experience volume overload. Okay, I could get dilatation and heart failure ultimately. So symptoms on here, that's usually there's really no symptoms at all. So again, mostly symptom free if the defect is small. If you have a larger defect, you can have early signs of heart failure actually. Okay, because you volume overload very quickly without a chance to really adapt. Tachypnea, okay, so breathlessness because all that fluid is building up in the lungs again. Poor feeding in the infants is common to see with some of these defects, okay, especially with a large defect. You can see early signs of heart failure in the infant, poor feeding, tachypnea, what we call failure to thrive overall. Lower respiratory infections, again, as I mentioned, dyspnea, and cyanosis, okay. And so cyanosis, remember, that's deoxygenated blood. And it causes that bluish discoloration. Now the cyanosis, remember these are what we're talking about, acyanotic lesions. So cyanosis would be a very severe sign showing that the circulation through the lungs is very much compromised to the point where we're not really getting good exchange and moving it into the left side of the heart and so on. On a physical exam, you'd hear a harsh holosystolic murmur. It's like a blowing murmur, okay? Smaller defects in this case actually have louder murmurs. There's higher resistance, but even you have a small defect, that's an increase in velocity that goes through there. That increase in velocity creates a lot of turbulence, and that creates a louder murmur. So again, the loudness of a murmur doesn't dictate or doesn't necessarily correlate with the size of the murmur in terms of a direct correlation with a louder murmur meaning a larger defect. In fact, in this case, louder murmur, it's a smaller defect, okay? Now, the important point I made under here is that if the pulmonary vascular disease develops, so let's say they start to develop pulmonary hypertension from all this volume overload, the murmur will start to diminish because the right ventricular pressures go up, flow is going to go down, right? Because we need a good pressure gradient. The pressure gradient starts to diminish as they start to equalize, so flow starts to drop off, and you don't hear the murmur anymore. So actually, as a murmur lessens, could be a sign that the fact that the right side of the heart pressures are actually starting to elevate. You might also hear a systolic thrill, or you feel a thrill, I'm sorry, you feel that vibration. And you might feel, the right ventricular heave, okay? You can feel that lift, that parasternal lift. In terms of diagnosis and treatment, chest x-ray is going to show that silhouette with an enlarged heart. But you might also see, a enlarged pulmonary artery, which is actually what this arrow here is pointing at. It's showing you this guy here, this very large pulmonary artery. And in fact, if you look down towards the base, you can see some good vasculature there. But if you look towards the, apices in the mid-lung region, you don't actually see a lot of good vascular markings there. And this is referred to as peripheral pruning. We have a large pulmonary artery due to all this volume overload and distension. But as it goes more distally into the parenchyma of the lungs and into the smaller arterioles, they've all sort of vasoconstricted to reduce that large pressure. So they've increased their resistance to avoid having any downstream effect on the capillaries and so on. And so that shows up like what we call peripheral pruning, where the vasculature is harder to see. On ECG, it's nondescript really. Left atrial enlargement, left ventricular hypertrophy might be seen. The echo, again, is going to be really a gold standard here. You can visualize the effect, measure the size of it, Doppler flow, and so on. Catheterization, as I mentioned before, that's you can see a step up in the increased oxygenation, and this time it would be occurring in the right ventricle. So it would be, superior vena cava and right atrium would look sort of normally deoxygenated, and then suddenly you'd see an increase in oxygenation in the right ventricle. In terms of treatment, by the age of 2, 50% of the small and moderate sized defects, they will usually undergo sufficient spontaneous closure, so there's really nothing to be done except to monitor. Surgical correction if there's a large defect, or if a moderate defect has significant amount of shunting that we're concerned for the function of the heart. The third one on my list for acyanotic lesions is the patent ductus arteriosus. Okay. Now, recall again that when we talk about acyanotic lesions, they're acyanotic because the shunting is from left to right, where we're taking oxygenated blood and moving it into the right side of the heart, which just goes through the lungs again and back to the left side. Okay. Now, in patent ductus arteriosus, recall that the ductus arteriosus connects that pulmonary trunk there to the aorta. Okay, and that's normal during fetal circulation. But if it fails to close, remember, it usually closes because the high oxygen tension causes constriction of those particular endothelial cells, and so it shuts off that particular pathway. And so they're showing the PDA here. If it remains open, it's connecting between the aorta and the pulmonary artery, and so it's it can volume overload the pulmonary vasculature, the left atrium, left ventricle. Okay, so again, pulmonary vascular, and then the left side of the heart. Now, risk factors for this, actually first trimester rubella infection is a known risk factor, as well as premature birth. In terms of the pathophysiology, normally, again, the smooth muscles will constrict after birth due to that sudden rise in oxygen tension, which reduces that PGE1. All right. Now, in terms of the flow, it's going to depend on how patent it is, right? That cross-sectional area, as well as the systemic versus pulmonic vascular resistance. Okay. What this basically means is if there's a lot of systemic resistance, that could shunt more blood towards the lungs and sort of increase the volume overload on it. If pulmonary vascular resistance goes up chronically, that could reverse the shunt even, or reduce the flow over time until it possibly reverses it. Failure to close results in that left to right shunt early on. Pulmonary circulation, left atrium, left ventricle becomes volume overload, as I already mentioned, and reversal of the shunt is possible if pulmonary vascular disease ensues. So the pressures go up and up and up. You can get the pressures high enough where it can reverse. Symptoms and physical exam, if it's a small PDA, asymptomatic, as most of these are. Okay, if it's a large PDA, same kind of story. We have heart failure type symptoms, tachycardia, poor feeding, slow growth, respiratory infections, fatigue, dyspnea, and so on. Okay, so it's a similar picture to what we've already discussed. On physical exam, what you're going to hear in this case is something called a continuous machine-like murmur. That machine-like, someone describes it as maybe like a washing machine or something like that, but usually you can hear it in the left subclavicular region, so on the left side, just below the clavicle, and you would hear it throughout the entirety of the cardiac cycle, from systole into diastole. The reason is because once the ventricle ejects the blood into the aorta still has a high pressure regardless of whether or not the heart is contracting, and that pressure is going to be higher than the pulmonic artery throughout the entire cycle. So it's constantly going to be moving blood from left to right. All right, and so that's why you hear it continuous. All right, so that's going to be the entire cardiac cycle. Now, pulmonary disease develops, as I mentioned. What you can end up with is lower extremity cyanosis and clubbing, okay, as well as something called differential cyanosis, which you can actually see up here. So again, these are normally acyanotic lesions, but they can progress to cyanotic, and the progression would take time. But in this case, let's say the pulmonary vasculature becomes high resistance, that can actually start to shunt blood in the reverse direction from the pulmonary vasculature into the aorta, because now its pressures are higher. And if it does that, it's going to be shunting deoxygenated blood, right, because it's bypassing the lungs, into the aorta. And then the aorta is going to be feeding that to the lower extremities, because that's primarily where the ductus arteriosus connects with the aorta, is on the descending portion, which feeds the lower extremities. And so now you get this more low oxygen tension blood going to the lower extremities, which can cause cyanosis, and prolonged can cause things like clubbing and stuff, which are signs of hypoxia. So differential cyanosis is actually something you might see here, where here the toes, you can see they're cyanotic. And you'll notice that the fingers are not. So it's differential because the upper extremities look normal and the lower extremities are cyanotic. Anytime you see this kind of picture, you should be thinking about a possible PDA, one that has progressed. So in some cases, some adults may never have had that corrected, and so it's progressed to the point where it's reversed, and now they're getting this deoxygenated blood, and they're becoming cyanotic in their lower extremities. Okay, so in terms of diagnosis and treatment, if we look at the chest x-ray, you can see enlargement and pulmonary vascular markings, which are similar to what we've seen. On ECG, things like left atrial and left ventricular hypertrophy. An echo is going to be useful because it can actually be used to detect the amount of flow that's going through there. Catheterization is going to show you something like a step up in oxygenation as you go from the right ventricle into the pulmonary artery. And in terms of its treatment, most of these will spontaneously close in the first month. However, if not, the PDAs are generally therapeutically occluded. So neonates, which means neonate is up to about 28 days after birth, and premature infants, they'll use prostaglandin synthesis inhibitors. Just to remind you, PGE1 is what keeps them open. So you want to inhibit that with something like indomethacin, and the loss of the PGE1 will cause the vasoconstriction and it can close. So indomethacin is would be one of the drugs of choice for this. Otherwise, you could opt for surgical ligation and actually cinch it off. And this ECG is just showing you, you can see these peaked R waves right here, which has been circled, and these deep S waves on the opposite side there, indicating that you have, some type of hypertrophy, left ventricular hypertrophy. Okay, so the fourth one on my list is coarctation of the aorta. So something that's coarcted has a narrowing. And so you can actually see here in the cartoon the narrowing that's occurring there. And what's important to notice with this is that the narrowing usually occurs around the ductus arteriosus. Now it can occur right at the level of, before, or just after, but it's usually in that area, okay? And the reason for this might be, it's not completely known, but it might be that the endothelium of the ductus arteriosus, which constricts in response to high oxygen tension, some of that may actually be kind of leaked out into the aorta in that region right there. So it also starts to constrict in response to high oxygen tension, which causes a stricture there. That's one theory anyway. So it happens right around that area there. So that's the coarctation. You'll see it's typically after the aortic arch, and you'll notice that the branches off the aortic arch here are usually not involved, but they could be. Okay, typically the left subclavian artery, if it is involved, it might be cinched off and actually closed off some of this left subclavian artery. It's associated with the bicuspid aortic valve. Okay, this often occurs in what we call Turner syndrome. So just to remind you guys, that's 45 chromosomes, so it's an X and an O. It lacks another X or a Y, for example, so we call it XO. And it's, again, as I mentioned already, located next to the ductus arteriosus. And if you take a look here, you can see on this X-ray film here, with some contrast, you can see there, this would be the ascending aortic arch, and then you can see the stricture at that point right there. That's the coarctation. So what happens is this actually impedes flow going to the descending portion of the aorta because it increases resistance, because essentially you have a fixed narrowing there. And so the left ventricle can actually face an increased afterload and hypertrophy from that. Okay. Now, flow to the descending aorta and lower extremities is going to be reduced, so you'd expect something like low blood pressures and so on. You can develop left ventricular hypertrophy, as I mentioned. All right, and you're going to get dilatation of collateral blood vessels like the intercostal arteries. And I mentioned this actually on another video when I showed this as an example. And so blood will flow through the intercostals, all right, as collateral flow to help feed the lower extremities and so on. Symptoms and physical exam. Shortly after birth, they could present with heart failure, depending on how severe the coarctation is, okay? Because that would be a very high afterload on a heart that hasn't had time to adapt. Differential cyanosis can occur, okay? Basically what happens is this: if right after birth, if they have a constriction, and that coarctation, I should say, is happening above the ductus arteriosus, and the ductus arteriosus is still open or patent, then actually that could be helpful in this case, because that can shunt some of the blood into and towards the lower extremities, bypassing that coarctation, because it would be a lower pressure system in the aorta there because of that upstream constriction. So that way we might be able to still move blood from the pulmonary circulation into the descending portion of the aorta there. That would also mean that we're getting deoxygenated blood towards the lower extremities, and so you might see some cyanosis there. And that's, as I mentioned a few slides ago, differential cyanosis, because it's happening after the aortic arch, and the aortic arch would be supplying oxygenated blood to the upper extremities and the head. If it's less severe coarctation, it's typically asymptomatic. Maybe they may have some mild weakness, particularly of the lower extremities, for example. Something called claudication, which we're going to talk in more detail on another lecture, but that's essentially like a ischemia of the lower legs when the demand is higher than the supply. And then upper extremity hypertension. So this is sort of one of these classic appearances here, though, where generally you should be measuring the blood pressure in the upper extremities as well as blood pressure in the lower extremities. And generally speaking, the lower extremities should have a higher blood pressure than the upper extremities. Usually the systolics are about anywhere from 10 to 20% higher than they are in the upper extremities. In this case, the blood pressure could be lower than the blood pressure in the upper extremities. And so a couple things you're going to see on the physical exam. A weak or delayed femoral pulse. So we check that pulse, it's delayed, especially compared to the radial pulse, all right, or the carotid pulse. Elevated blood pressures in the upper extremities. It could be you may see elevated blood pressure in both the right and left arm, and then low blood pressure in the leg. If coarctation involves the left subclavian artery, as I mentioned on the previous slide, sometimes it can involve that last branch there, the subclavian artery, then you're going to see a reduced blood pressure on the left arm as well as the lower extremities, but you'll see an elevated blood pressure in the right arm. All right, so you see it in the right arm, and again, it's typically anywhere from greater than like 15 to 20 millimeters of mercury in the right arm compared to the leg. So this is important why we always measure both arms and the leg, so we can compare them, because if you see that there's a decrease in the blood pressure in the legs relative to the arms, then it's a good indication to actually look into coarctation. You can hear a murmur, systolic murmur, heard over the back or the chest in the area where that stricture is, because it can create some turbulence. In terms of diagnosis and treatment, chest x-ray. Chest x-ray is actually very useful and can be diagnostic here. The little arrows, I've actually shown you this x-ray before, but these little arrows here are showing you where the subcostal arteries are, and as it's creating collateral blood flow, it flows underneath the ribs there, and it can create notching. So you can have a notched ribbed appearance because it kind of erodes the underside of the ribs there. And you can also see the little dotted line, there's a little 3 there, there's the 3 sign. So the indentation here is really where the coarctation is occurring in the aorta. Okay, so that's the 3 sign. On ECG, left ventricular hypertrophy. You might see an enlarged silhouette of the heart as well in the x-ray. The echo can actually visualize and determine the pressure gradient across the lesion, so it can make some useful measurements. MRI CT can detail the length and severity of the lesion itself, so how much of it's coarcted and what's involved and so on. It gives you some more detail. Now the neonates, again, these are the younger, about 28 days after birth. If it's severe in the neonates, prostaglandin infusion will be used. Recall that if I keep that ductus arteriosus open, that could actually help get blood flow to the extremities. So if you have a very severe coarctation to the point where you're not getting much flow down there and you don't really have time for collateralization, then keeping the ductus arteriosus open would be useful. So you can infuse prostaglandins in this case. This is the opposite of indomethacin, which would try to close it. So we'd keep that open in order to maintain flow there before we can get them to surgery. Okay, so it's something transitional. Okay, that wouldn't be a permanent fix. In terms of surgery, you have to get excisions. You can cut out the area that's actually constricted. All right, and then it's a reattachment procedure or a sleeve, and then you can also do a transcatheter balloon dilatation in certain circumstances. Okay, so I'm going to move on now from the acyanotic now to the cyanotic, and what defines the cyanotic is obviously going to be cyanosis, and this is going to be due to the fact that earlier on you actually have a right to left shunt. Okay, that separates it from the acyanotic, which early on has a shift or a shunt from left to right. This is now right to left. So we're taking deoxygenated blood and moving it over to the left side, which then moves out systemically and causes cyanosis. Okay, so two of the ones I want to talk about, and there are others, but the two main ones I want to talk about are Tetralogy of Fallot. Okay, sometimes it's been referred to as blue baby syndrome, and transposition of the great arteries. Now, actually on this slide right here, I want to talk about the transposition of the great arteries. This is the most common cause of cyanosis during the neonatal period. Okay, in that first 28 days of life. This is the most common cause of cyanosis. And so, to understand transposition of the great arteries, it's just like it suggests, is you actually have the aorta and the pulmonary artery are switched. They're transposed, right? So this is the normal heart over here. So just to recall, here's the right atrium. Okay, so here's the right atrium, right ventricle, right? And so that normally goes into the pulmonary artery, which goes to the lungs, back to the left atrium. You guys know this whole pattern, right? Left ventricle into the aorta. If we switch the aorta and the pulmonary trunk with each other, this is what happens. Now I have systemic venous blood going back to the right atrium. That moves into the right ventricle. And instead of going into the pulmonary artery, that's going into the aorta. The aorta then goes and feeds the body, right? The rest of the systemic circulation. Problem here is it never went to the lungs. So what I have is now I have two parallel circuits running next to each other. They're not in series any longer. So obviously you can see this, this requires an emergent surgery because, all right, if we have, again, blood going into the aorta and it's going to come back through the vena cava and it never went through the lungs, it's staying deoxygenated. On the other side over here where I have the left atrium and the left ventricle, and when it ejects, instead of going into the aorta and feeding the systemic circulation, instead it's going into the pulmonary trunk. So on the right, the left side of the heart is very well oxygenated, but it's not serving any purpose. Okay, it's not actually delivering any of that oxygen to the systemic circulation. And so I have the formation of two parallel circuits. In cases like this, they may try to opt to keep the the septa actually communicating, like the atrial septal defects and whatnot, or the foraminal valley. They might try to keep that open so that there can be some communication, the ductus arteriosus and so on, so that there is some communication between these two in order to get them to the surgery. And in the surgery, there would be, again, sort of a switching of the vessels. Now, in Tetralogy of Fallot, okay, this is where you have essentially a single developmental defect, and this is where there's an abnormal interventricular septum. So you notice the interventricular, so there's the right and left ventricle. You can see that there's an opening there, and so there's communication between these two ventricles. All right. Now, this is going to cause most commonly a right to left shunt. Now, this isn't like a typical VSD that I've already mentioned where it's a left to right shunt. This is actually the reverse, and this is because of these other four anomalies that occur along with that septal defect. So I have the ventricular septal defect, but I also have pulmonic stenosis. So that's right here. The outlet from the right ventricle into the pulmonary trunk there is stenosed. It's narrowed, which means it's high resistance. Okay, so it's not likely to move blood into that region because of that resistance. So it's more likely to actually shunt it towards the left. Now, in addition, you have an overriding aorta. The aorta itself is not positioned directly over the left ventricle like it normally would be. Instead, it's positioned over the septal defect. So it's being shared essentially by the right and left ventricle. So that's what we call it overriding. And then you have right ventricular hypertrophy. So these are your four characteristics that you can see when Tetralogy of Fallot. Ventricular septal defect, so there's communication, an overriding aorta, pulmonary stenosis, and a right ventricular hypertrophy. So if I have pulmonary stenosis, that means I'm not moving blood into that high resistance area as easily, which means I'm actually assisting the left side of the heart in pumping blood mostly into the aorta, that means I'm assisting in systemic circulation, which means it's going to hypertrophy as well because the systemic circulation is a higher resistance. Okay, this is the most common form of cyanotic congenital heart disease after infancy. Okay. So Tetralogy of Fallot, its pathophysiology, increased resistance by that subvalvular pulmonic stenosis. All right, this causes deoxygenated blood returning from the systemic veins. It gets shunted through the VSD into that overriding aorta. Okay, so that's that right to left shunt. This results in deoxygenated blood mixing. Okay, and the infants become hypoxemic. All right, and they can become cyanotic. Now the magnitude of that shunt, all right, depends on, again, the size of the VSD, how much the pulmonic outflow tract is stenosed. The more stenosed, the higher the resistance, the more you're going to shunt, right? Now, on physical exam, in these children, okay, you can see, now again, this is just, I want to reiterate this point though, this occurs during infancy, and you can see this in toddlers actually. So, 1, 2 years old, you may not see symptoms develop right away. And it could happen at around that age. So you can see a 2-year-old, for example, exerting these symptoms. And so they may have dyspnea on exertion. Okay, and this is often referred to as a tet spell. So they start to feel very winded when they're running around, and they can become very irritable. Okay, they become cyanotic. So when it's occurring during this tet spell, you can see bluish discoloration around the lips. So in the cartoon here, you can see perioral right there. You can see it in the fingers and the toes. Okay, they may start to hyperventilate. Again, trying to oxygenate. They could undergo syncope. They could have fainting spells. It could cause convulsions due to the low oxygen content going to the brain. All right. Now, usually with these TET spells, when they start to feel irritable or cyanotic and they hyperventilate, they may, alleviate those symptoms by squatting. So when you see, a very young infant, or let's say a 1 or 2-year-old running around, stopping, getting very irritable, and squatting, this could be a sign of something like Tetralogy of Fallot. And what you'd see on a physical exam would be cyanosis, okay, hypoxemia, again because of that shunting, clubbing because of the changes that occur in the fingers and toes, a right ventricular heave because the right ventricular is hypertrophying, and you have a murmur due to a stenotic right outflow tract, okay, which could cause like a crescendo, decrescendo kind of murmur. So the question is now, getting back to this squatting, when they squat, it seems to alleviate the symptoms, and the reason for this is that when you squat, if you recall, during the heart sound lectures, we do these maneuvers to increase or decrease volumes to the heart. When you squat, you can increase volume to the heart, but it's got a little more complexity than that. Squatting does increase volume to the heart, which would just cause more shunting and so on. So that wouldn't seem to help necessarily. However, when they squat, they're also crunching down and they're compressing vessels at the hips and at the knees and so on. And when you can physically compress those vessels like that, what happens is you're increasing afterload. You're increasing resistance. So it's twofold. You can increase volume as well as increasing resistance and afterload. So in this case, by increasing preload and afterload, primarily that afterload, that actually keeps more blood, or increases the resistance to blood being ejected into the aorta, and allows more blood to be ejected into the pulmonary vessel. Okay, so by increasing resistance to the aorta, I can then hopefully shift a larger percentage of that blood into the pulmonary circulation. And so that's where they might get some alleviation. Okay, in terms of diagnosis and treatment, chest X-ray has this very characteristic, what they call boot-shaped heart. You can kind of see that in this cartoon that I took off the internet here. You can see the shape of the heart. The ECG, right ventricular hypertrophy with right axis deviation, is fairly common. The echo is going to be sort of your gold standard here because you can detail right ventricular outflow tract, the anatomy, and also the ventricular septal defect and any kind of changes in hemodynamic flow. In terms of surgical repair, there's palliative therapy, where you actually create an anatomic communication between the aorta and pulmonary artery, or the subclavian artery and the pulmonary artery. What you're trying to do essentially is create a communication wherein the blood that's moving into the aorta, some of it can get shunted back to the pulmonary artery, bypassing that stricture and hoping to increase flow to the lungs. Now there are some other surgical procedures, where they would actually use a patch to close the VSD, and they would try to enlarge the subpulmonary outflow tract so it reduces its resistance. So I just want to take a second to talk about the Blalock-Thomas-Taussig shunt. Okay. In particular, with this shunt, I want to just describe this gentleman here, Vivian Thomas, which you can see over here, in his younger years. And this gentleman actually had no education past high school, and he worked his way up to having an honorary doctorate, and he was a surgical assistant, so he was like a physician's assistant, and an instructor at Johns Hopkins Medical School. And he actually helped to design this particular shunt here, which is connecting the subclavian artery to the pulmonary artery in cases where of patients who had blue baby syndrome, more frequently known today as Tetralogy of Fallot. And this helps to redirect flow from the arteries, you can see the arrow, to the pulmonary circulation to help offset the cyanosis. And the way he did this is he actually was working on dogs and trying to reproduce the Tetralogy of Fallot in these dogs and then do surgical procedures to see if he could rescue them. And he ultimately was successful. And one of the successes he had was with this dog right here, Anna. And Anna, interestingly enough, is actually a painting that's hanging up in Johns Hopkins currently. And in fact, since he was able to demonstrate success in this procedure, he was then asked to assist on doing the procedure in the operating room on humans as well, and they found great success with it. Okay, Eisenmenger syndrome. In Eisenmenger syndrome, this is really what I was kind of alluding to with the acyanotic lesions. Remember, acyanotic is shunting from left side to right side. So it's already been oxygenated, but it's shifting it back to the right side and getting reoxygenated. So you're overloading the right side of the heart a lot. And then, as I mentioned, you can overload it so much that the pressures start to go up on the right side because the lungs start to hypertrophy in response to all this volume overload. And the arterioles in the lungs will actually start to constrict to reduce the amount of volume that the capillaries are seeing to prevent things like pulmonary edema and so on, which would really worsen the situation. But as those pressures go up, you can actually have chronic changes occurring to the vasculature in the lungs themselves. And that's actually what you're seeing in this cartoon over here with the thickening of the wall. And you can see a very, very narrow lumen right there. And so resistance can get very high. And as the resistance gets higher, that can actually cause backup pressures. All right, so it can cause an increase in pressure in the right ventricle, right atrium, and so on, and a reversal of the shunt. So Eisenmenger is actually the term for that reversal. So this would happen sort of more chronically. And so if you have severe pulmonary vascular obstruction, all right, now you are going to shift your left to right. It's going to shift now from right to left. And when that happens, cyanosis occurs. So that acyanotic lesion over time can become cyanotic because of increasing and rising pressures in the pulmonary vasculature. Because of that cyanosis and lack of oxygenation, they can develop erythrocytosis, so high red blood cell count, which can actually increase their viscosity, right, and increase their overall resistance, put more strain on the heart. The systemic vasculature would vasodilate in response to all that hypoxia, which would actually worsen this scenario, increase the shunting because now you have less of an afterload, and so it would shunt more blood in that direction, which would maybe worsen the cyanosis. So it's sort of a vicious cycle. And ultimately, if this occurs, this may require something like transplantation of the lungs. So since I brought it up and I'm talking about pulmonary hypertension a few times, I just want to kind of briefly touch on pulmonary hypertension. By definition, pulmonary hypertension is a mean arterial pressure greater than 25 millimeters of mercury at rest. Recall that pulmonary pressures are generally much lower than systemic pressures. The mean arterial pressure systemically in the aorta, for example, would be right around 93 to 95 millimeters of mercury. So in the pulmonary circulation, it's about 25. You have several things that can cause increased or rising pressures in the pulmonary vasculature, and one of them that arises is passive. And so in passive, this is resistance in the pulmonary veins. So commonly what you see with this is on the left side of the heart. So if you have left-sided heart failure or say mitral stenosis or something of that nature, that causes volumes to build up on the left side of the heart, which backs up into the lungs because it's increasing pressures in the veins. And then to overcome the rising venous pressures, the arterial, the arterioles of the pulmonary vasculature has to actually start to increase its pressures to overcome the venous pressures. And so pulmonary hypertension ensues. You can also have hyperkinetic, and so hyperkinetic is secondary to left to right shunts. So that's what we've been talking about with the VSDs and the ASDs, okay, where these increasing volumes are causing increasing rising pressures on the arterial side. And so you get vasoconstriction and hypertrophy of the vasculature, which causes narrowing. Then you have obstruction. Obstruction would be something like a pulmonary embolus. So that would cause a blockage, which causes an increase in resistance very quickly. Pulmonary artery stenosis. Okay, so you could have some sort of connective tissue disease as well, which might actually cause constriction there. Obliteration, collagen and vascular diseases, which actually cause those connective tissue diseases, causes constrictions, which reduce flows and increases pressures. And then, any kind of vasoconstriction, recalling that if somebody has a lung disease, remember the lungs, the vasculature dilates in response to oxygen and constricts in response to hypoxia. So if somebody has a hypoxic lung disease, something like COPD, for example, they may have more vasoconstriction, which is going to increase resistance, or any other kind of cause for hypoxemia that can cause vasoconstriction. Now, we classify pulmonary hypertension into these 5 groups, which I put a little cartoon here for you guys. So there's a group 1, which is actually group 1 is pulmonary arterial hypertension. In pulmonary arterial hypertension, the prognosis is not very good. All right, it's usually a 2-year survival from the time of diagnosis, most often seen in young or middle-aged women, actually. Typically, this is idiopathic, so unknown causes. It could be an inherited disorder. It could be due to drugs or toxins, infections like HIV or schistosomiasis, connective tissue diseases like CREST syndrome, for example. And it has a very poor prognosis overall. Group 2 is due to left heart disease. And it's actually the most common cause of pulmonary hypertension, and it's actually the one that I've discussed in the heart failure lecture itself. Okay. Group 3 over here is due to the lung disease. So COPD, as I mentioned, or some other reason for hypoxemia, which causes vasoconstriction of the pulmonary vasculature. Group 4 is pulmonary hypertension due to chronic thromboembolism. So thromboemboli constantly blocking up and occluding, causing more and more resistance to flow. Something like this might be seen in somebody who has a tumor that's releasing a lot of emboli. Group 5 is sort of the bucket at the end, which is really, hypertension with unclear multifactorial mechanisms. So it's sort of our bucket group there. Now, in terms of clinical features and treatment, somebody with pulmonary hypertension, they're going to be, short of breath, right? They might be breathing quickly, so they're tachypnic. The shortness of breath may only happen when it's, with exertion. They're fatigued because they don't exchange oxygen very well, which the body needs. The chest pain might occur. It might be exertional, so it might sort of mimic like an anginal type pain, because as the heart starts to work harder and it doesn't get the oxygen supply it demands, you can get ischemic type pain. Syncope. Again, this could be due to poor cardiac output due to higher pressures in the lungs, not transmitting enough fluid to the left side of the heart. You may have a loud P2 and a heave, and the heave is from the right ventricular hypertrophy from the high pressures, and the loud P2 because you have high pressures in the pulmonary vasculature, which sort of slams shut the pulmonary valve. In terms of treatments, really, since there's such a wide variety of things that can cause it, many of which actually have other treatments for them. Really the goal here is to treat the underlying disease. That's why I put it in bold, right? So if they're having left-sided heart failure, you have to treat the left-sided heart failure. If it's HIV, treat HIV, and so on. And hopefully it's at a stage where there could be some recovery and not too much loss of function. However, if you're in that group 1, which I mentioned has a poorer prognosis overall, there are still some treatments that you can use. Inhaled nitric oxide, which can cause vasodilation. They may use calcium channel blockers in certain cases because that'll help the smooth muscles vasodilate. You obviously wouldn't use this in cases of acute severe heart failure, because we want the ionotropy to help the heart contract. Some specific therapies that are using now to help target this would be PDE5 or phosphodiesterase 5 inhibitors, which actually help to increase nitric oxide levels. Endothelin 1 normally constricts these vessels, so endothelin inhibitors can help to vasodilate the pulmonary vasculature and hopefully help increase the circulation and drop the resistance. In some cases, you may need anticoagulation. When you have backed up pressures, you can get stagnation of flow, which can lead to thrombosis, plus this could lead to things like AFib and so on. Diuretics can be used. Again, you want to use it sort of judiciously, but diuretics can help kind of offload some of the volume that may be backing up into the lungs or into the systemic circulation. Home oxygenation therapy is helpful in many cases, as the oxygenation, again, this is really if the desaturation is getting below, let's say, 90% or so. This would help to actually cause vasodilation by increasing the oxygen tension in the lungs. Ultimately, in cases like group 1, for example, transplantation may be your only option. What you can see over here, this is actually a case of schistosomiasis, so this would be a group 1 pulmonary arterial hypertension. And in this case, when you look at the CT, you can see this cross section. I just want to draw your attention to this structure right here. I'm going to outline it for you there. This right here, this region here, this is, by the way, using contrast, so they're looking at blood vessels. This right here, I'll mark it as a 1. That's actually the pulmonary trunk. And this area over here and this area over here would be the pulmonary arteries. And you can see how wide those are and dilated they are. Okay, and again, that's because of that backed up pressure of the pulmonary hypertension. Over here, what you're actually looking at here is the ascending and descending aorta. But you see these very wide dilated pulmonary arteries. And then if you look over here, you can actually see these large pulmonary arteries. And you'll notice that the rest of the lung, you can't really see much vasculature. And I mentioned this on the earlier slides, where this is like peripheral pruning, where the arterioles constrict so much, they don't let much blood flow through at this point, so the tension is very high. And so you actually see very little vascular markings there. Okay, so on this slide, I just want to touch on the fact that congenital heart disease is often associated with genetic abnormalities. And I've put a few here, and by no means is this an exhaustive list, but let's just take a quick look. So we have Down syndrome. Down syndrome is trisomy 21. There is a 40% incidence of congenital heart disease, such as like ASD, VSD, and PDAs, so the acyanotic lesions. Turner syndrome, which I've actually already mentioned previously, which is 45XO, and that's the coarctation of the aorta, which is also associated with a bicuspid valve. Williams syndrome, deletion on chromosome 7, which actually codes for the elastin gene, and that can lead to supravalvular aortic stenosis and arteriopathy. I haven't actually talked about supravalvular aortic stenosis in this lecture, but just in brief, that's the stenosis above the aortic valve, and it can actually cause an increase in afterload and so on. DeGeorge syndrome is a microdeletion on chromosome 22, and it can lead to Tetralogy of Fallot and something called a truncus arteriosus. And so just briefly here, truncus arteriosus, this is where you have communication from the left side and the right side of the heart via the ventricular septum. You can see there's a defect there. And in this case, what you have is one trunk that actually leads to both the pulmonary arteries as well as the aorta. They share the same outlet. And so in this case now, what you're having is mixing of both the venous and arterial blood, which causes cyanosis. So to finish up, I have a case here I want you guys to take a look at. So go through the case, take a look. I just want you guys to be aware that on this particular slide, this echo, I will show you the video of this echo when we talk live, because the echo here is not showing you a whole lot right now. But take a look at it anyway, take a look at the x-ray. And then finally, take a look at the ECG and see if we can put a picture together. Good luck, guys.